Hi, I'm Tim Redline, pharmacist with Redline Compounding Pharmacy, and I want to talk to you a little bit about the recent news that the FDA is planning to remove the black box warning on estrogen replacement products. This is big news. I did a video on this last week, a much shorter one, but I wanted to spend a little extra time because there's a lot to unpack. Now, the black box was originally applied to estrogen products in 2003, and you can see it here. The major risks that they added to the labeling for estrogen products in 2003 was the risk of cardiovascular disease or heart disease, breast cancer, and the risk of strokes. Now, these risks all came from a study that was published in 2002 called the Women's Health Initiative, or WHI. And this was a very large study, 16,000 women, but it was very poorly designed. It was supposed to be a menopausal hormone replacement study, but the average age of the women in the study was 63 years old. The average age of menopause is 51. So the average participant was 12 years past the average age of menopause. And they also used two estrogen and progestin products in it that were synthetic. They used Premarin, which, as you may or may not know, is derived from pregnant mare's urine. Those are horse estrogens. And Premarin was first developed and FDA approved in 1942. So it had been around for a long time. It really gained in popularity in around the 1960s. There was a book published about hormone replacement and really gave that a lot of fuel and became very popular. In around 1989, a synthetic progestin was approved called Provera. And what they were finding was that women who took Premarin that still had a uterus were developing uterine cancer. And so what they did is developed a synthetic progestin called Provera, or medroxyprogesterone acetate, and combined it with Premarin and called it Prempro. And that would help protect women from uterine cancer. And it worked very well to do that. However, both of these hormones are synthetic and they were used in this study. And unfortunately, the results of the study, which you can see here, were applied broadly to all forms of hormone replacement, whether they were synthetic or bioidentical. This uh, chart here is from a PowerPoint presentation that I did in 2006 on this topic. I found this in our archives and thought it would be neat to show it here. Just going over the results of this study. And they found that the risk of stroke and blood clots increased in both groups, patients who took Prempro and also who took Premarin. The risk of colon cancer was neutral, roughly in both groups. Heart attacks were increased in the Prempro group and no change in the Premarin group. And then the risk of breast cancer increased in the Prempro group and actually decreased in the Premarin group, which was interesting. And then the risk of hip fractures decreased in both groups, which is not surprising because estrogens have always been good to help strengthen your bones. So here's FDA Commissioner Marty McCary in an interview with PBS NewsHour explaining how and why this major change came about.
Many experts say that risk does not exist for many menopause hormone therapy candidates. To help explain today's announcement, I'm joined by FDA Commissioner Dr. Marty McCary. Commissioner McCary, welcome back to the NewsHour.
Good to be with you. Thank you, Ali.
Why is the FDA making these label changes?
Well, the fear machine that started 23 years ago with this tragic, misinterpreted study and the results has resulted in a distorted perception of risk. And about 50 million women since that time have been denied, never offered, or convinced out of hormone replacement therapy, including all of its short-term and long-term benefits. And some of those benefits are profound, including reducing the risk of cardiovascular disease and heart attacks. That's the number one cause of death in women. And no study subsequently has ever found, no clinical trial has ever shown that the risk of breast cancer mortality is increased with hormone replacement therapy. So women deserve all the facts, and women's health issues have historically not gotten the attention they deserve. And this
Estrogens were and continue to be the single best treatment option for menopausal symptoms. It's really unfortunate because cancer survivors were denied estrogen. women who had uncontrolled symptoms that affected their relationships and quality of life. Dr. McCary mentioned they estimate around 50 million women were denied hormone replacement therapy because of that flawed study and the broad application of those results. They also estimate that in the year 2000, approximately 1 in 4 women, menopausal women, were taking hormone replacement therapy. After that study was published in 2002, 2005, that number dropped to 1 in 20 women. So you can see how few women were prescribed hormone replacement therapy. In this next clip, the FDA commissioner is asked about the broad application of these recommendations when estrogens are used locally, transdermally, and orally. Let's listen.
In terms of the perception of risk, I want to break it down. There's two types of estrogen, broadly speaking. There's local, which can be a cream. It's applied directly to an area. And then there's systemic, which takes the form of a pill or a patch and works its way through the bloodstream. This announcement today is going to apply to label changes for both. Some experts say that that is too broad of a move because the risk-benefit ratio for systemic estrogen is a little bit more nuanced than that for local, and that actually these two types of estrogen should be classed completely differently. How do you respond to that?
Well, that's right. Tragically, the black box warning was placed on all estrogen products, be it local or systemic. Now, for the systemic estrogen products, there is an important nuance that will be in the package insert, and that is if you start it more than 10 years after the onset of menopause, that risk-benefit ratio inverts, and most doctors do not prescribe it after age 60 or after 10 years after the onset of menopause. And that's an important distinction because maintaining a continuous level of intrinsic estrogen or exogenous estrogen through these hormone replacement products is probably critical to maintaining a high level of nitric oxide that keeps the blood vessel wall soft and healthy. And that may be why we see such a dramatic drop in heart attack rates long term. In one study in Circulation from 2 years ago, a 48% decline in heart attacks that were fatal and a 30% decline in all-cause mortality. Also, a significant reduction in the rate of bone fractures later in life and a reduced rate of cognitive decline. Those are the long-term benefits on top of alleviating the short-term symptoms of menopause, the hot flashes, night sweats, mood swings, and weight gain.
That was a great question by the interviewer. We don't want to make the same mistake again and broadly apply these recommendations when there are clear differences when it comes to synthetic versus bioidentical and oral versus transdermal application. But let's first talk about local application. I wrote about this in 2016 when the American College of Obstetrics and Gynecology came out and recommended that using vaginal estrogens was safe for breast cancer survivors. Now, this was quite a change back then in 2016. And I sent this out to our providers in our newsletter to try to get the word out. Researchers found no evidence of an increased risk of breast cancer recurrence. Unfortunately, so many breast cancer survivors have continued to suffer because of the slow uptake in the use of locally applied vaginal estrogens. Now, when it comes to oral versus transdermal application of estrogens, that's taking a pill versus applying an estrogen patch or a cream to the skin. I wrote about this in 2018 when we kept talking to menopausal women who were denied hormones because they had a blood clot early in their life and maybe in their 20s. Now, that blood clot was probably from birth control pills. We all know that birth control pills can increase your risk of blood clots, but transdermal estrogens do not affect blood clotting. It is thought that it is the first pass metabolism in the liver from oral estrogens that can increase clotting factors. So what are the key takeaways? Hormone replacement therapy can reduce the risk of bone fractures. We've known that for a long time. It can reduce the risk of heart disease. Now that's a 180-degree turn from where we were before. Estrogen replacement does not increase the risk of breast cancer mortality, studies show. And hormone replacement therapy may reduce the risk of dementia and cognitive decline. And the timing of when to start hormone replacement therapy is very important. So where do we go from here? All of this should be welcome news to both healthcare providers and patients and should make it easier to have discussions about hormone replacement therapy. Now, hormone replacement therapy still isn't for everybody. There still are risks to take into account, but this should make that discussion a little bit easier. So if you're a woman having menopausal symptoms, go talk to your healthcare provider and just start asking questions. And if you don't get anywhere with them, give us a call. We'll be happy to assist. And if you're a healthcare provider, this should make it easier to talk to your patients about the risks and benefits of hormone replacement therapy. And if you're still not sure, we've been helping providers for 2 decades navigate hormone replacement therapy with women using compounded bioidentical hormones, and we'll be happy to assist you as well. So I hope this information was helpful. I hope it can put your mind at ease. There's still more to learn, still more questions to be answered, but I'm glad to see the FDA taking this action and removing these warnings that should have never been there from the beginning. Thank you.